So, HTN nerd.ai, new nerd.ai. You're thinking about pivoting the company.
I am. I saw how well the pivot went for our favorite shoe manufacturer last week, and I figured, why not us? That seems like a good idea. I know about as much as GPUs as the next person who knows nothing about GPUs, so we should be able to execute on this pivot, right, Martin?
Well, we're missing a couple key ingredients. I don't think that this is, deal breakers, but number one, Allbirds has a public ticker,
True.
which helps them sort of, raise the money. And number two, there's like a sort of, I think, a lot of affection for Allbirds in the Valley. I think everyone, has fond recollections.
Are
Not
you
that
implying there's not affection towards health tech nerds in the Valley, Martin?
I think it's different. I think it's just like a different connection that folks have. But the
Fair.
financing structure, we should get Sean on to talk about this at some point because it is kind of interesting. But the financing structure here is funny. So like an investor does something called a death spiral convertible, where
It's
they are
literally called a death spiral convertible.
well, I don't think that
But
Allbirds or the investor would call it, but that's what people call it.
yeah.
And basically what it does is they issue these convertibles, and they are allowed to convert at a price that is lower than whatever the current market price is for the stock.
Okay.
Not at a set price like most convertibles, but at a price that is just lower.
Whatever is lower than the current price. Yep.
Yeah. And so they can convert whenever they want and sell stock, and then keep on doing that. And the reason why it's called the death spiral convertible is because eventually you convert into a couple pennies. And
That makes sense.
yeah,
It in many ways reminds me of the conversation we had a few months back about the failed biotechs becoming shell companies for as Bitcoin treasuries. Like you have a public ticker, and therefore shenanigans ensue when your business isn't going as anticipated. I don't know.
that's pretty much exactly it. So it is almost the top of the hour. We've got an incredible show today. We're talking with Neel Shah about the great unbundling of maternity care CPT codes. We're talking about alternative plan design with Russell and Will from Yuzu. We're talking to Shiv from Abridge about their new expansion into clinical decision support, and then Patrick Sheehan from Withings about access and connected devices. But first, at the top of the show, we got some stuff to talk about in terms of the news of the week. Kevin, do you want to kick us off by talking about this great highlighting job you did for Access?
A lot of skill went into this one. Yeah, Access last week, obviously top news from the week. You and I both covered this in newsletter. The initial list of 150-ish participants came out Monday afternoon by CMMI. I found it fascinating to go back to the original launch event, which was late 2025 when we were talking about that. And this slide that we've got up on screen, which highlights I think it was 68-ish initial participants in that list. And what immediately jumps out to me, Martin, is there's a lot of red on this page. It seems that a handful of the digital health companies that evaluated the access opportunity looked at the rates after they came out, because that was kind of the big difference between then and today, right? The concept of this program, the outcomes-based payment, the excitement around that doesn't seem to have changed. But what has changed is companies have seen what the rates are and seemingly said, this is too low to operate in. We're going to dig more.
Oh, yeah. I was just going to ask, what do you make of that? I think like the talk track we've heard, sort of memorably, Chris Klomp said, we're not going to let this incredible technology, AI, pile drive or healthcare pile drive it into the ground. What do you make of the fact that, 150 is not nothing, right? That's a lot of people, but that so many of the original interested parties said, no, thank you.
I think it's indicative of the change that CMMI is trying to drive and the question mark that's still out there on whether or not they can do it, right? Clearly, they've got companies raising their hand saying, we're interested in this. We're going to talk with one of them later today in Withings. I'm curious to see how they evaluate the opportunity. So the opportunity is there. The interest is there from these companies. It's worth noting that they haven't committed to anything yet by applying and indicating that they want to participate in the program, right? This is not a commitment. So they could still, I don't know the exact mechanics of this, but my understanding is they can still opt out before the program starts on July 5th. So it's indicative of the gap I think that exists between, if you're CMMI trying to drive this change and implement this new payment model, and you're the digital health industry, the digital health industry, as I understand it, is looking at these rates and building up financial models and saying, hey, based off the way we think about this, we can't make this work. And at the same time, CMMI is saying, well, we want you to think about it differently and actually build a new model that doesn't build from the ground up. And to me, that, like, that's the most interesting element in all of this is you've got, going back to what Klomp and others say about this, like CMMI has been pretty clear in my mind that you're going to need to be an insurgent to win in this model. You can't think like an incumbent building backwards from what exists today. You've got to rethink the whole model. And I don't think anybody would call the digital health industry the incumbent class in healthcare, but that's kind of the implication, isn't it, Martin?
Yeah,
Like,
I've been thinking about this a lot lately, and I think it's, it would be premature to say, okay, CMS said AI is this potentially transformative technology. We're going to put that out. We're going to call your bluff and say, like, if you can deliver care at very low marginal costs, you can win with access. We're going to actually pay you a lot if your marginal cost is close to zero. Then a lot more people should be raising their hands. And so I think it would be premature to say, like, well, this proves that AI can't deliver care at zero marginal cost. But it does raise a question for me.
yeah, for sure. I mean, we have heard that narrative a lot. I think we've both expressed our skepticism towards that narrative over time, and I think this reaction embodies that skepticism, right? It's like, okay, CMS is in some ways asking the industry, in my mind, to put their money where their mouth is and drive this change. And the industry has said, guys, we can't do it at these rates. Which as I understand, like there's good reason why they're opting out, right? Like you look at the build cost, and between the cost of acquisition of patients, between the cost of procuring devices that you need to send out and whatnot, the cost of actually even just AI phone calls, like there's a stack of costs that these companies would still need to incur to operate these programs that are not nothing. And then on top of that, as I understand it, there's some policy nuance in this too of how the payments actually flow and some of the potential concerns of if you're participating in the program and you're expecting payments from the program and somebody else is participating in traditional fee for service model, like what happens if another company comes in over the top to take that patient? Have you just invested and you're now losing those costs? So as I understand it, there's some of those questions too that presumably will get worked out over time, right? Like as I've heard it from CMMI, they recognize that this is a model that will change in time. If that's a big risk, I would think they would address that, right?
I remain of the opinion that access is an incredibly cool thing for our federal government and CMMI to be trying out. It's a great experiment, which is, can you deliver care with very low marginal cost? Historically, the answer to that question has been a resounding no. And it's cool that, we'll see how many of them actually start participating, but 150 people raised their hand and said, yeah, we're going to go give it a try.
Yeah.
I don't know.
I think you and I think we're both in the camp of you want to see this program succeed, right? If AI is really going to bend the cost curve, this programs like this have to work, right? Like it can't be the answer that this access doesn't work because rates are too low. Maybe there are iterations of it that are needed to come, but like it has to work. So I'll be cheering it on for sure.
In the newsletter, I talked about my favorite Gallup poll from a decade and a half ago, which says like Medicare is a increasingly high percentage of the budget. Would you prefer raising taxes or reducing benefits? And like overwhelmingly, the American people say, no, we would prefer you didn't do either of those things. And to me, access is like one way to get out of that choice, right? If you say, we don't want to reduce benefits, we don't want to increase taxes, like you need something like a transformative technology to really make this thing possible. And so that's why I'm kind of crossing my fingers for it. But it is hard to do. And probably we will have to raise taxes or lower or reduce benefits.
Yep. So start of the trade-offs.
Talk to me a little bit about your peptide stack these days, Kevin. You're doing the Wolverine stack, I think, is what you were sharing.
I would say I'm still in the contemplation phase of whether or not I should be doing the Wolverine stack. I cannot say that I have partook in the Wolverine stack, I suppose, yet. But yeah, that was one of the other big headlines from the week. I think it was Wednesday afternoon. This wasn't a surprise to folks following the peptide space, but the FDA came out and said they're going to start the process of considering whether or not they will ease the regulations around peptides. In part, this, RFK has been signaling this seemingly for a bit now. The gray market around acquiring peptides from Chinese manufacturers is a concern. And I suppose if instead you manufacture them here in the States and have a green market, I suppose, for peptide manufacturing that you can keep an eye on better through compounding pharmacies and whatnot, that is a better outcome for that space. There, if you read the headlines from it last week, there's some concerns about whether or not this is going to encourage this kind of Wild West behavior and gold rush towards the peptide market. Seems like we're pretty clearly headed in that direction, regardless of whether or not it is Wild West or this is a good thing. I don't know. We're all going to find out over the next coming months, years in this general landscape. So it's going to be interesting to keep an eye on. The one thing I do know is that investors and entrepreneurs are seemingly gearing up for this opportunity as peptides go mainstream in this country. Hims stock, I think, was up 50% last week, just starting after the news came out Wednesday afternoon. Clearly, investors are excited about the opportunity for it to leverage peptides as its kind of next phase of growth for the business. Superpower came out, I think it was Friday afternoon, and announced that they've got their wait list. So if you're looking to get in on the peptide craze, you can join their wait list as they prepare their product for launch. There's a company called Protocol. I think it's pronounced Protocol with a E at the end of it. Is that how you think you pronounce it? Yes. They came out with a more clinical grade model for peptides. They raised seed funding and came out of stealth. And interestingly, and this is where I find the space fascinating in a sign of maturity of it. Ultralight, which is an EHR platform for longevity clinics, kind of peptide space adjacent, they came out and raised $9.3 million. They used to be known as Vibrant Practice. It's being used in 75 longevity clinics today, which to me is indicative. Like when you see the derivative plays of a market, like an EHR for longevity clinics raising that sort of capital, it is indicative of the market opportunity that investors are looking at as they build their spreadsheet saying, okay, this company is going to offer this for these 75 clinics. The math you got to do on the number of clinics and the offering for an EHR to get into that space, it's indicative that they're expecting it to be a big market.
Moving on from peptides, Brendan Keeler in the HTN Slack shared a study, looked at New York State providers, and found after the implementation of price transparency, you're not going to believe this, providers raised their prices. And
no.
Yeah, I know. That's not supposed to happen. It very quickly escalated into a conversation about Danish concrete. Are you familiar with the Danish concrete study?
I've heard you reference it before, but share for the community who hasn't heard
it's
it.
just great. Okay, so if you're a huge nerd, you think about Danish concrete a lot. So the concrete market in Denmark is pretty concentrated, and in the late 80s, Denmark basically said, we're going to require price transparency for concrete manufacturers. One of the things that they didn't really, on the assumption that it'll make the market more efficient.
Mm-hmm.
And one of the things they didn't really think through is that it's actually very hard to ship concrete across the country of Denmark or really anywhere, you kind of need to go to your local concrete provider for that. And there's basically all monopolies. And so if you have a monopoly and you make prices transparent or a quasi monopoly, everyone just kind of starts raising their prices a little bit. It allows you to collude without, breaking the law. And so there's this famous paper talks about basically, here's the market. It was really concentrated. Whoops, prices went up. And this is something you and I come back to all the time. There's a lot of folks who say, man, if we just had transparent prices, things would be so much better. And there's really not good evidence for that. It wouldn't hurt if we had hyper competitive markets, but most hospitals in most states are kind of in their own little monopoly, or there's one or two other options. And if you make prices transparent, they're just gonna raise their prices.
Yeah. I think there's enough evidence at this point of price transparency coming in, prices going up. No Surprises Act being another example of that we've seen, certainly, that I've come to expect that to be the case. Not to say that I think price transparency is a bad idea. Like, I think both you and I would agree price transparency should be in these markets, but it alone isn't going to drive costs down in healthcare. You need to couple it, to your point, with a whole smorgasbord of other changes in these markets too. I would think.
Yeah. There's really never one weird trick that doesn't involve something painful or
But wouldn't it be easier if there was, Martin? Like, I want the one thing. We need to give Mark Cuban his one talking point that is magically going to allow us to fix healthcare. And price transparency feels like a good one. I don't know the prices, damn it. It's confusing.
If you are interested in seeing or watching a fight on LinkedIn start to develop, you can go to Kevin O'Leary's LinkedIn where he's calling out Mark Cuban. But before we get too into that, one of the things that thematically has come up last week when we were talking to Andrea from Simply Fed is the great unbundling. And this is a fascinating topic to me. It's a fascinating topic for a bunch of reasons. Kevin, while I bring our guests forward, can you tee us up for this conversation a little bit?
Yes. I must admit, I felt pretty oblivious to this topic even 2 weeks ago. And then I read a blog post from Neel Shah, who's joining us here, who started talking about this great unbundling of maternity care and the transformation that's happening from a payment rate perspective, kind of going from value-based care bundle payment concept to more old school fee-for-service type mindset in the maternity space. Neel, really excited to have you on today. Excited to learn more about what's happening in maternity space, and wanted to see if you'd just start us off with, historically, what's up with this bundled payment and maternity care? What drove this change today, and what should folks looking at the space expect to happen over the next kind of coming 12 months, 24 months and beyond?
First of all, I need to hang out with you guys more because anybody who's like, there was a paper once on price transparency is like good friends with me. But yeah, so historically, now we're talking like for a full generation, going back like 40 years to the 80s, the way maternity care was paid for in the United States was this one big bundle. And, healthcare is complicated. We've had this idea of bundles for a while, but particularly following the Affordable Care Act as a way of paying for value, whether it's a joint replacement or even some kinds of cancer services. And the notion is if you pay for a whole episode of care, you're less likely to get the fee-for-service incentives of, getting paid to utilize more than you need to. And pregnancy and maternity care is like one of the most bundleable things. It's got, a starting point, an end point, a pretty predictable set of services. And for a long time, that bundle seemed to serve its purpose. And we can get into it, but I also kind of saw this innocuous email from the American College of OBGYN a few months ago saying that the bundle was going to end. And it seems like this really wonky technical change, but it will actually change the way maternity services are not only paid for, but delivered for the next generation of people pretty substantially.
Can you give us a peek into the future of like what this is going to look like practically if you're having a baby or happen to be a clinic that does maternity care like Maven?
Sure. I mean, maybe let's start with like the why. Like, why are they changing? I mean, this was one of the fears of healthcare where you're a purchaser or just a person having a baby and trying to start a family. There's a very predictable way of paying for care for the most part. But the bundle was starting to get stressed by the fact that in 2026, the doctor you see in the office is rarely the doctor that delivers your baby anymore. That used to be most of the time, and now it's like pretty rare for that to be the case. And so that creates complexity around who should get paid what within that bundle. So team-based care changed things. And also technology has changed radically in the last 40 years. You still can't deliver a baby through a screen. There are some limits when it comes to maternity care, but the first ultrasounds used in pregnancy was when I was born, and I'm 44. The first IVF baby in the US is the same age as me. So, and that doesn't say anything about, genetic screening and a lot of the more advanced therapies that we have today. And so the bundle didn't do a great job of accounting for that. And so a lot of people said that it was stifling innovation. Nobody knows exactly what's going to happen when we fully unbundle, but the decision was made that we're just going to pay for things piecemeal now. And in the process of reporting on this, I talked to the CPT committee at the AMA. I talked to payers. I talked to clinicians on the ground. And it's designed to be budget neutral. So the AMA does this, and they go to CMS and they tell them it's a budget neutral change. But that means that you're going to pay more in some places and less in other places, and that's where the rub comes. So if you take care of high risk pregnancies, you'll get paid more. If you have a high risk pregnancy, you will pay more, or somebody will pay more. And probably what will happen is if you have a low risk, straightforward pregnancy, the payments will go down. And that has implications also.
Neel, when you say the payments will go down, this is the question I was going to ask you, kind of, squeezing the balloon concepts. I hear the theory a lot of somebody's going to get paid less. And one of my lessons learned getting into healthcare innovation over the last decade is that doesn't seem to materialize all that often. How are costs going to go down? Is it rates go down for the low cost for the lower risk pregnancies, or what's driving that shift?
I mean, so I'm told that we're full steam ahead. This is happening on January 1st, 2027. There are a lot of open questions around implementation, and there's a lot of additional guidance that I think we're meant to be getting around modifiers and things like that, Kevin. But like part of my role at Maven is to guide purchasers and what they should expect. And part of what we're aiming to do also is plug access gaps. And one of the people I interviewed along the way is Boris Bakari, who, by the way, you should have on because he's imminently quotable. But he's got a company called Claimable, and he's really on the front lines of American frustration with the American billing system. And one of his better quotes that he gave me is he called unbundling the original sin. And he was like, Neel, what happened when they unbundled your cable? Did prices go down, to your point, Kevin? No, they did not. Now I pay for 5 streaming services. Or he was like, remember the quaint old days when you just paid for airfare and also covered your meal and your baggage? It's like, how does it work now? So, I mean, I think ultimately for a lot of purchasers and a lot of people, prices will go up. My worry, though, is that particularly in rural America or independent practices that were already serving people with really marginal or really thin margins, the incentive to take care of lower risk people might go down. Right. And so they may shift to make more money. But the fundamental truth is that if you are a straightforward person, your pregnancy will cost less.
I'm curious about your view on how. So I hear the argument that he's making about unbundling being the original sin. The sort of rejoinder to that is like a lot more people fly today than could fly when everything was bundled together. The question I have coming from the kidney care space is the bundled payment for kidney has done an incredible job of keeping dialysis payments low, but it's also, I think, stifled a lot of innovation. And I'm curious what you're seeing is like, what are folks in the market missing out on because it just doesn't fit into the bundle?
What a time to be alive, Martin. I mean, like right now we live in a moment where, preeclampsia has been a scourge for humanity since forever. Like it's an ancient Egyptian text as this thing that kills pregnant people, and even today it's one of the yeah. we have tens of thousands of years of history. Basically, since there was written language, we're describing this mysterious disease of pregnancy, and until basically today, we had no idea what it was. But now we can use free-floating mRNA that's in the maternal bloodstream from the fetus and identify someone who's going to get severe preeclampsia months before they do with no apparent risk factors. That's one of like a million examples I can give you. Oura Ring, is really good at sensing thermal shifts, which happen right around the time of ovulation, but also happens right before people go into labor. And when I was on call in the hospital, the only way I knew if I was going to be busy is if there was a full moon. But now we live in a world where maybe we can predict labor onset, something that I thought was impossible for my entire career, right? So there are all of these emerging technologies that have not translated into routine practice because we haven't had a construct to pay for it. And I think it's a totally reasonable argument that the old bundle was stifling innovation in a way. The question is whether we should have thrown the baby out with the bathwater and whether there's a better bundle, at least as a concept. But it's a totally fair question. I think that the expectation is that certain types of innovation will be easier to bring to market this way.
Neel, one of the things I think I read in the article was that it was kind of on this point of bundle stifling innovation, and that removing this bundle will actually allow for more innovative payment constructs to come to fruition as well. I'd be curious if you could expand on that statement a little bit, and also what you're seeing. What are the implications for the employer market, more broadly speaking, for a company like Maven working with employers to manage maternity costs? Like I would think that's where some of the opportunity now lies to rethink what a bundle is there. How are you guys processing this and thinking about the opportunity and new forms of alternative payment models?
Well, I mean, I think the one thing that we're certain of is that there'll be more uncertainty, right? And basically, like the nerdy way of talking about it is volatility.
Yep.
Right. And wherever you see volatility, there's an opportunity to think creatively about risk and risk management. So it's possible that there could be a world where you see, willingness to take on risk in different ways now that there's more volatility. There are some purchasers that we serve at Maven that have a baby every 12 minutes somewhere in the world. A lot of them skew towards higher risk, and we are projecting that they're going to see higher total costs of care as a result of the unbundling. And so it argues for stronger and more effective care management. One of the things that I'm excited about with the unbundling is that we'll have much more granular information about the services that are being provided, because people are going to be billing at the service level. And you can't fix what you can't see. And so we'll have much better visibility into services. And so theoretically, I think like you and Martin were talking about this right when I came on, but price transparency by itself isn't good enough. Mm-hmm. I think Abraham Verghese once said, if you're ordering off a menu that has no prices on it, it's really easy to get the filet mignon every time. And so like conceptually, price transparency should help, but you need some kind of accountability mechanism with it. Right. And I think those are where a lot of the open questions are. Is like, okay, we'll be able to see which services people are getting. We'll probably have a point of view on whether they're the right services or not. But then what is the accountability mechanism to sort of make sure that we're course correcting?
I'm, an absolute tourist in this area. I have a 10-month-old, but aside from that, no real sort of on the ground research expertise. I used to work for Medicaid though. And one of the things that I find amazing is, Colorado Medicaid, they have this doula program and the results are like incredible. It seems to me like doulas are one of those things that are maybe like under reimbursed today. And in a new model, we can, that sort of takes it out of the bundle. Are there anything that you're sort of excited to see in terms of technology or process or care management that you think is going to be better compensated going in this new paradigm?
First of all, I love that lead up because, having a 10-month-old gives you plenty of street cred, because I delivered thousands of babies before I had to take one home, and I feel like that really changed my perspective. But then casually dropping that you also worked for Medicaid. But listen, I think that doulas are an example of the only public health intervention that consistently works for everything, which is the community health worker, right? Whether it's directly observed therapy for tuberculosis in Haiti, or like cholera treatment, or, like community health workers work. And there's a ton of evidence. And I think that there's also a lot of momentum for state Medicaid systems to reimburse for doula services. I think 26 states now and growing. And that is great. And also, Medicaid works from a scarcity mindset and reality. And so doula reimbursements crowd out other services. And fundamentally, the challenge is that childbirth is one of the highest value services, I would argue, that our health system provides. But we don't pay for it the way we value it. We pay much more for end of life care in the ICU, or other things. And it's hard to, like, all of our health services are valuable, but relative to the way I think society ought to value childbirth, we probably don't do a good job of paying for all the services that people would benefit from, including doulas, but including everything else.
I appreciate the dots and Partners in Health shout out.
Yeah. Well, it's a nerdy podcast, so I figured I'd go there.
Yes.
Neel, I'm curious on the awareness front, how you see this playing out over the coming months. As health tech nerds, I like to think that we keep our eye on stuff that's happening. Certainly,
I'm so proud of myself for scooping you.
Yes, we appreciate that.
Yeah.
That is how we learn in the Slack community. It strikes me that I imagine most employers aren't aware of this change or haven't fully processed it. Brokers are still in a processing phase of the change at hand. I was reading an article this week talking about what employers are thinking about in terms of managing costs and its alternative plan designs and transparency and primary care models. How big of a deal is this going to be for employers, for the large employers who are having a birth every 12 minutes? Would you expect that come 2027, this is going to be rising up the lists of, hey, we need to think more about maternity now that this change is coming to play? Or what's going to be the impact among employers, and how should brokers be thinking about that too?
This is going to be a slow burn story. So the story is not over. Like this is like ground zero. We're pointing out that this is happening. I think more smart people like yourselves are going to start paying attention and weighing in as we learn more. And then, CMS is going to spend years studying what happens and theoretically making adjustments accordingly. But I will tell you, in effectively breaking the story open, I have never seen more interest in anything that I've ever tried to talk about from the purchaser community, because this wasn't on a lot of people's radars. Even, the health plans have to update all their systems.
Yeah.
There are practices on the ground that are just beginning to contemplate what this means. And some are projecting significant revenue shortfalls as a result, and others are counting on being winners. So there's a lot, I think, that that we're likely to learn. But I think it's possible that some purchasers of healthcare whose populations skew towards being higher risk will see cost increases of up to 10%. And it's not just the folks who have a baby every 12 months. If you were to take the entire GDP of the United States and spread it out across a table, you could see the cost of hospitalizing moms and babies with your naked eye. It's 0.6% of our whole GDP. It's the most utilized healthcare. It's 25% of all hospitalizations are a mom or a baby. So if you're a Medicaid system in Colorado, or if you're, a commercial purchaser or a union, everybody's going to see and feel this.
Yeah.
Neel, we're at time and unfortunately can't keep you longer. We didn't get a chance to talk about Maven's expansion into fertility, so we'll have to have you back, or expansion of the fertility and family building programs, excuse me. For folks who haven't read it yet, if you go to mavenpreprint.substack.com, you can read The Great Unbundling by Neel, which is what prompted this conversation. It is very fascinating. Neel, where can folks learn more about Maven and get in touch with you if they want to?
I think Substack's a great spot. I think it's this wonderful medium where people like to read, and so you can write a 5,000 word long form article about The Great Unbundling and have people pay attention.
And we are. We really appreciate your time today. Thanks so much. And like I said, we're already looking forward to having you back.
You bet. Thanks, guys.
Good seeing you, Neel.
So I thought you teed it up nicely as a sort of transitional topic on this question about what does this mean for employers? Like the dominant thing that we hear whenever we're hearing anything today is about how squeezed employers are when it comes to healthcare costs. And this feels like a real sort of punch in the teeth in terms of like, well, we're taking one of your highest cost things and we're gonna unbundle it and make it even higher cost.
Yeah, and like, can you imagine being HR team at an employer? You're trying to wrap your arms around what you need to be doing, the programs you have in place, and then all of a sudden, some group decides that maternity care in this country, like 1/1/27, we're changing how we pay for it. Surprise, guys, have fun. Like, go figure it out. Like, what? I just conceptually, it's so wild to me. Like, it's crazy.
Yeah.
And ultimately, like, we talk about the iron triangle all the time. It seems like this is playing out in real time in front of us. You can like see the calculus. Hey, we are improving access and quality, and it might cause these issues for cost because cost might go up, right? Like, these trade-offs are, but if costs don't go up because we have a balanced budget perspective, somebody's getting paid less. And Neel articulated the concern if somebody is getting paid less, that has implications for low-risk rural pregnancies, right? Access might be shut off for those. And like, you can see it in real time, which I find fascinating. Neel's point on that being a slow burn, it's going to be interesting for us to watch over the coming years.
This is one of those things where forever I thought of bundles as this great technological innovation, and they are, but there's trade-offs with them, and those trade-offs are right on the quality side, and we can do so much more than we could, even 10 or 20 years ago. But up next, we've got a couple of folks from Yuzu, and we're going to be talking about alternative plan design. They just raised a $35 million round, and the Yuzu story is, I think, a really fascinating one. So I'm really excited to chat with the guys. There's also a Minnesota connection, which we love to see.
Let's go
on this podcast. But yeah, I think that as we are thinking about, I talked to the folks from Sidecar last week. It's like this question of how do employers save money on what is increasingly a larger and larger line item of their business is a salient one. Like, we don't really have a good track record of saving money in healthcare, and it's exciting, or will be exciting, to talk to a couple folks who are working on that. So I'm going to bring Will and Russell out front. Welcome, guys.
Thanks for having us. Really appreciate it. We're a big fan of Health Tech Nerds. Both Will and I have been a member of the community for years, and I think you guys ask great questions. I hope we can tell our story and be valuable to your listeners.
Yeah. So, are you both from Minnesota?
Yeah, I'm a 6'12". He's a 6'5" though.
Nice.
Ooh.
Nice.
I like it.
Yes, we repping Minneapolis as always. They're not actually from there, but went to college there, and it's my favorite city in the whole entire world. So one of the things that I find most fascinating about Yuzu is that you all started off as a health plan. Can you give us a little bit of the backstory there on what it was like trying to build a health plan?
Yeah, absolutely. I think it was an incredibly humbling experience more than anything else. We started out basically knowing very little about insurance, except knowing that it was broken, which I think is apparent to many people. And we just kind of like kept asking why. And I think we were inspired by, at the time, Sana Benefits, when me, Max, and Ryan, my two other co-founders, were kind of ideating and trying to figure out how to build a business in health insurance. We wanted to kind of bring what Sana had done to small businesses in Texas to startups. We figured out quickly that there's like a lot of issues with that business plan. But I think number one issue that we kind of figured out is that like building a health plan is just really hard. You have to have actually differentiated benefits. I think a lot of people think that it's just about figuring out how to kind of use data better or like find some quick wins. we found that actually when we got on sales conversations with companies, they didn't want to hear about like how quickly we would administer something or how tech forward our interface could be. I think they just wanted to know like what are the trade-offs that like you're making that are going to help my employees, like what are the costs, et cetera. And so we figured out quickly that like we had to either have a thesis about that or we had to kind of pivot our business model. And so we ended up kind of in a little bit of like a lurch for a while where we didn't know exactly which direction to go. But we were inspired by the people out there that were building actually differentiated plan designs. And so this was kind of insight number 2. If insight 1 was that tech doesn't fix the problem, insight 2 was that there are people actually fixing the problem. And so it took us a while to kind of understand what was going on, but we saw, plans being built around direct primary care and plans being built around kind of navigated cash payment that were starting to actually go to these employers and employers that were in need of a different health plan. For what it's worth, tech employers are not in need of a different health plan. Was another insight that we had. I think a lot of people want to sell to startups, and that's probably great in the software industry because they're cutting edge. But in the kind of health plan industry, the employers that are most at need are the ones that are actually like struggling to afford benefits. And so we were able to connect with plans that were doing that were selling to these employers, and they were doing so kind of with new ways of building reference-based pricing plans, centering DPC, and then kind of navigated cash pay. And so that was kind of insight 2, is like these people exist that are making change. And then insight 3 was really that, maybe we can actually be valuable to these plans. And so what they wanted was a completely re-architected kind of claims flow, different ways of kind of like, they needed something all in one because they couldn't afford, they weren't at a scale where they could, bring on like a dedicated member portal or a dedicated kind of like invoicing solution. They needed us to be all in one. And then they wanted us to just kind of build with them and listen to them, because I think we've kind of co-invented a lot of things together with our partners. And that wouldn't have been possible if we, didn't kind of start out at a small scale where we were able to really craft our product around their business needs.
Russell, Will, we're having this conversation on the heels of you guys announcing a $35 million round. So clearly you guys have figured out kind of that pivot towards this model. I'd be curious the underlying momentum you guys are seeing with this TPA approach y'all are taking to the market. And you talked a little bit about how it's not the startup community who's the go-to-market strategy for a product like this. What is the employer you're selling to like today? Like, paint the picture for me in my head of like, who is the employer, who's the target customer, and what's the pitch conversation like with them? Like, how does that go today?
Yeah, I can take that one. So predominantly, Kevin, so far we've sold to alternative health plans. So it's like there's this growing kind of like market movement around plans who have found kind of the insight that we found early on, which is like the self-funded renaissance. And like self-funding is unbundling, right? But then they're bundling back in and basically going to market, competing with like BUCA carriers as a bundled approach. And so like those are the people that we actually sell to. So like we go in as the newfound payer platform plus TPA services. So it's like those two components, and we basically power those alternative health plans. Those alternative health plans tend to be regional, some are national, but they, to Russell's point, are typically in the small, medium-sized business market, and like they're employers who are like hurting and like are basically like enough is enough. Like they're the CFOs who are actually like digging in, right? And being like, what can we do here? And are open to actually crafting like these new types of innovation within their plans. And so that's like typically the market of like the end employer user, skewing blue collar a little bit, typically hyper local, some national. But they're the ones who are looking for these alternative health plans, and it's like really led to like the blossoming kind of growth within this alternative health plan market, which like we are there to power. Does that make sense?
Yes.
Yeah.
Sure.
And can you kind of give us some sort of vignettes on like what these plan designers' theory of the case is?
Oh, totally. I'll just give you like, okay, so almost always these employers or these plans are winning on price. So like like just to beat kind of the book of care and everything, it's like almost always people are building or like winning on price, and we like enable like different kinds of types of innovation to come to life for them to win on price. In terms of how they do that, like it's been actually really unique to see across the programs that we like power. Some are really tapping into like underwriting innovations, right? And like bringing kind of like the self-funded, level funded down market. Others are like tapping into like cost of care innovation. So like enabling kind of like more direct payment, cash payment, capitated primary care that Russell talked about. Others are actually innovating on like clinical innovation and like bringing kind of like a Kaiser-esque closed loop system, very handheld kind of like experiences to these employers. My favorite story, my favorite like vignette is this employer group, a couple thousand employees across multiple states. They had rolled from a fully insured carrier to a self-funded carrier about 6 years ago, and then rolled into an RBP plan like 3 years ago. Saved a bunch of money. Members were not getting better care, right? They had the rub of like RBP, access, balance billing issues. So they come to us and they're like, hey, we've got this crazy idea. We want to pair people throughout these 13 locations in South Carolina and Texas to dedicated direct primary care physicians and give them unlimited primary care access. And so like we built the product to enable that sub-assignment of members, right? And then they're like even crazier when that person basically wants to go into their like specialty care arena when it's necessary, we want to pay at the point of service. And so then we built basically Yuzu Cash Pay, which allows pre-adjudication onto a cash card to pay these independents at the point of service. And so like 1/4 of people throughout eligible employees jumped onto this plan in 1/1/2025. And like 80 to 90% of medical claims last year were pre-adjudicated cash payment. And it's like awesome. And so like members were super pumped, right? $0 care for them if they followed guidance. And the employer basically saved more than the RBP plan. And like the best part is this, basically like the person who was doing the care coordination is named Brenda. She's awesome. She's like so awesome. And upon open enrollment this year, there was literally employees across the country who were saying, I love Brenda. I want the Brenda plan. And enrollment doubled this year, like doubled. It's awesome. Like, and like who's talking about that? Like in their health insurance, you know, and it's super cool. And that's what makes like Russell and I proud.
That's really cool. Yeah.
Yeah.
The Brenda plan.
I'd be curious, guys. So we were just talking with Neel Shah about the change in maternity space and how that payment model is changing from bundled to unbundled and how that might drive increased costs for employers. I'd be interested to use that as an example of kind of the change afoot in the employer market. Are you guys proactively keeping an eye on stuff like that and surfacing that and designing kind of, here are the options in maternity care that y'all should be looking at? Are you letting employers sift through that themselves and come to you guys? Or how does change like that flow through with your plan offering?
Yeah, it's a good question. First of all, I'll say that we support probably about 10 plans and they each have like different ways of doing this. Some of them on the more basic side are just Cigna plans, and they pretty much, you know, they've got an underwriting and a distribution strategy, but in terms of like how people get care, it's pretty much just the Cigna pre-certification process. The more innovative plans, though, our take is that the best ideas come bottoms up. And so actually we don't really believe that sort of like we're pretty far away from the member and the care coordinators that might be within these health plans. And we believe our job is to pretty much enable them to be creative and to have the tools that they need to access the right trade-offs for members. And so although we do have products that like notify care coordinators who exist at our health plan customers about like pre-certifications, about eligibility checks. We kind of have an integrated communication model so that care coordinators can see every time someone got a welcome email or an EOB or whatever and see the claims in real time. But in terms of like ideas for doing care coordination, those come bottoms up. And I think that that's kind of the way we see ourselves as a vendor of these health plans instead of them being a vendor of us as like care coordination vendors. Like we see ourselves as like administration vendors of them, because this idea of like how are we going to communicate, you know, care options to people, that is the hard part 100%. And we've seen some like ridiculously creative things that have gone on because there was a high level of trust between those care coordinators and patients and employers. And so we've seen, waived everything to go to a surgery center out of state. We've seen, people kind of actually like lining up colonoscopies back to back to back to back to save on anesthesia. We've seen like weird stuff that we could never have actually coordinated ourselves. And even if we did coordinate, it wouldn't have come from like that position of trust and that position of caring for a member and really like knowing what's going to work best for them. And so I think our take is that even though health plans think they have all this data, there's only so much that ICD, like that HCPCS codes can encode. And you really want to be able to utilize the kind of contextual information that exists on a more local level. And to do that, you want to almost figure out how you can trust and incentive align with people that already have that information, whether it's the referring doctor, whether it's a care coordinator, whether it's the employer or the member themselves. And so that's kind of like our take is to wrap around them and try to make sure if we trust them, we want that person to be super powerful within the plan. And have kind of the ability to waive certification if necessary and all this other stuff. And so we have to record those events and make sure that they're visible to stop loss carriers and other partners, kind of our model. But we want the kind of right decision, whoever has that right decision, to be able to make that right decision. And it's not always, and not even usually, us on those creative kind of care navigation events.
There's clearly a lot of interest and demand for alternatives to the current system, especially at the employer level, right? Costs are going up every year. It's unpredictable. It's just like a bad situation. I sit in Washington, D.C., and most of the attention, it feels like from my perspective in Washington, D.C., is about ICRAs. I'm curious for the House view on from Yuzu on ICRAs and what policymakers should actually be focused on if it's not this ICRA.
Yeah, I will say I've got a blog post on yuzu.health/blog about this. If you want,
I did. That was a tee up for.
Yeah. I would say ICRA is not solving the fundamental problem of just how do you balance things within the plan. The most inefficient parts of a health plan are really like network access, pre-certification, kind of payments taking a long time and being difficult to understand and organize, and those things are not solved by ICRA. And so ICRA does kind of give members some choice over how to spend dollars. And I do appreciate that it's bringing employers kind of more, like another topic to think about as they kind of craft benefits. But I don't think it solves the fundamental kind of challenge of kind of network access, pre-certification, kind of what's covered, what trade-offs are being made at like the group level. And so I think like we kind of early on considered being an ICRA platform and decided it just didn't go deep enough for us, and that we wanted to go a level deeper. And I think it's kind of like concerning that the incumbents in insurance are not scared of ICRA at all. They're the ones that are lobbying for it. And so I see it as an extension of the status quo. But that said, I think there's been some players in the space that have gotten good distribution and brought attention to the right issues. And they might be able to kind of launch their own plans on some of that distribution and trust that they've built.
I think we're at time. And so if folks want to get in touch and learn more, besides reading the really great ICRA post that Russell did on the Yuzu blog, and if I do say so myself, a fantastic interview with Russell that we Health Tech Nerds did a couple months back. How can folks get in touch? How can folks learn more about Yuzu if you're a creative plan designer who's got a theory of the case for how to make things better? What's the best way for them to get in touch?
Yeah, my email is will@yuzu.health. Russell's is russell@yuzu.health, or trickle into our website. There's a bunch of good content in the blog. It depicts who we are and how we work. So I'd also point you in that direction. And before we wrap too, I just want to say thanks to you guys. Both Russell and I are Minnesotans. We've been a part of the community for a long time. I remember before I joined over 3 years ago, I would see Russell posting just outrageous questions in the Health Tech Nerds Slack channel. And people were keen to respond to him, they jumped in. And Russell has a good blog called Asking Dumb Questions. And people were welcoming of that, and taught us a lot. And your community has fostered that. So we're thankful for you.
That's really
we
nice.
love it. Yes.
Thanks, guys.
Thanks for joining, guys. Appreciate
All
you.
right.
Always fun talking to fellow Minnesotans.
All right.
Amen.
Bye. I think that the alternative plan design space is like one of the more interesting conversations that's happening, and seeing like hearing like
Sure.
lining up back-to-back colonoscopies, like the create to save on anesthesiology is like one of those things where you're like, yeah, that's not, I think it's basically impossible to do at scale. And if your employer comes to you, like Kevin, if you came to me and said like, it's colonoscopy day at Health Tech Nerds, and we're all taking a field trip to, I'd be like a little bit skeptical, but I think it's just, I don't know, I just think it's like fascinating that you can kind of pull these sorts of things off.
Yeah, it reminds me a little bit of the convo I had with Tom Freeman from the North Carolina State Health Plan the other day about some of the things they're thinking about in terms of managing costs. And like, it actually, if you are a forward-thinking employer and you've got the support and mandate to go do some creative things, I think to what Yuzu just raised, you can do that. I mean, ultimately, you're the one paying out the healthcare dollar. And so it's a really interesting role to be running benefits for organizations like that and thinking about what can you do to get creative, right? There are all the news stories about, can you send people to different countries to get their medications because they're cheaper and you can pay for the whole stay. I think Tom Freeman mentioned you could pay for a limo and hotel stay to get people at the right spot. For surgeries, there's all sorts of wild different stuff that you can concoct if you're in one of those roles.
Yeah.
But it is fun. I think, I mean, given cost increases that employers are facing, we're clearly going to be talking about models like this a lot more, right? And to me, it's just, I have these questions in my mind of large group versus small group, how that changes, how those are potentially different and or not different. The ICHRA conversation is certainly an interesting one. I know there are a lot of opinions in the industry on where ICHRA is heading, how that materializes for small groups, but orgs like Yuzu have a real opportunity to help drive some of those new different plan designs, particularly for forward-thinking employers, right?
It's a lot. There's, speaking of ICHRA and the ACA marketplace, there's been some news this week on the subject. You pointed out in the newsletter that Baylor Scott and White Health Plan is exiting the ACA market and their Medicaid plan. What's going on over there?
I saw that article come up. I don't know that I was looking for details on, backstory, the why, et cetera. I didn't find much beyond they're exiting the markets. I think you and I both. Yes, I think we both have a theories. Let me hear yours.
Well, it's a really bad time to be an ACA plan, and there's a lot of tumult and uncertainty. And
Is it a good time to be a Medicaid plan?
Oh, it's a way worse. Just way, way worse. So, off the top of my head, that's sort of what I expect. And
Martin, when Mark Cuban Cost Plus Wellness is just sitting there in your market, why do you need an insurance arm to begin with? You should just be the low-cost hospital provider in your market and contract directly with employers, because you can just get rid of all the inefficiency that exists in the ecosystem.
Yeah, you can just, that money was not well spent, and smart people haven't been trying to do this for a long time. Oregon also placed a plan under receivership, which, yikes. I think the plan is called Atrio.
Yep. I had not heard of Atrio before personally, but yeah, I mean, it's another example of a plan that I think it had 36,000 Medicare Advantage members, so not a small plan, but it lost $50 million in 2025. It only had $10 million in capital and surplus. I think I was reading that they potentially had some unpaid claims to providers that they were being sued over in addition to that. Put this under the broad theme we've talked about repeatedly about the challenges facing regional health plans today. Between this and the Baylor Scott and White Health Plan example, it is a tough time, I think, to convince me that it is, good as a single state provider sponsored health plan and or just regional health plan in general. I think it's a sign of the times.
Well, Wakely released their first, it's basically the first data point we got on effectuated enrollment. It's not the official effectuated enrollment in the ACA marketplaces, but this is their sort of back of the envelope math based on January premiums paid and and a couple other things. They're saying it's looking like January paid premiums were about 85.9% of the total enrollment. So it'd be a roughly 14% loss from the numbers that CMS published in the beginning of the year. That is less than some plans were expecting. Now, that's a national number, and so you don't read too much into that and say, okay, these plans are saved, these plans are screwed. But in general, I think that the sort of golden path for plans this year was enrollment being low and them sort of benefiting from enrollment being higher than expected. And it seems like that's maybe going to happen.
Yeah. It's so Weekly, I think in the report said that they're expecting on the whole enrollment declines to be between 17% and 25%. So back to your point, in my head, this I get a little confused on in the ACA, but so this report was people who had coverage in January but didn't pay in January, but they have a grace period that's longer than that. And so Weekly is saying over the next couple months, in total, it's going to go from 14% up to in that 17 to 26% range.
That's what I thought. But it's actually...
Is that not right?
I think what they're saying is at the end of the year, that's what enrollment's going to look like. Because there's always a lot more churn. So that was I was like, oh, wow. So the grace period for the ACA, if you have a subsidized premium, you get 90 days. But if you have a subsidized premium, I think that number will likely go down, right? It'll probably actually be less than 85.9. But the universe of people who have subsidized premiums and don't pay their premiums should be lower than the total universe of people. I'm going to actually pull up a slide that will help me make my point. So Wakely included this sort of helpful graph, which was premium increases by paid premium percentages. Basically, the more premiums went up in your state, the sort of higher the more premiums went up, the lower the percentage paid of premiums is. If you have a subsidized plan, this is pretty intuitive. If you have subsidized rates, you're probably going to use that subsidy, but not 100%. So I think 14% is like a pretty good mark for effectuated enrollment. We'll see though, because CMS hasn't released it yet. The grace period kind of just ended. Recently.
What's your take on Wakely also seemed to indicate that the morbidity in the market was going up 2 to 6%. What was your take on the morbidity numbers and what that means for plans?
So this was expected, right? The ACA original design was saying everyone has to have insurance, and that's how we're going to solve this problem where we have adverse selection. And then we got rid of the individual mandate because people didn't like it. And now the way that we kind of handle the adverse selection problem is by pumping more money into the system, by giving more generous subsidies. So we knew that if the subsidies expired, things were going to get, the risk pool was going to get sicker. It makes sense. If you don't think that you need insurance, you're not going to buy it because you don't have to. And so we knew it was going to go up. I think the question is that those are pretty wide error bars, like 2.9 to 6.5% morbidity shift is pretty significant. And it feels like, again, the happy path is a lower morbidity, lower attrition than expected, and then lower morbidity than expected. And so as we tune into earnings calls starting over the next couple weeks, like this is going to be what's going to be interesting to talk about.
Yeah, for sure. As we wait for Shiv to hop on here, we can keep talking about this for a couple more minutes. One of the interesting things I recall hearing, I forget if it was an earnings call or blog post or whatnot, but it was talking about the fact that this may actually play into 2027 as well. Which back to one of our other general themes of uncertainty in markets, like it's going to be interesting to see how quickly we can clarify what's going on here, what that implies for folks, actuaries in these plans who need to underwrite these policies, because those decisions are coming up pretty quick for 2027.
Yeah, we also haven't gotten the final rule for 2027, the 2027 ACA plan market. So the administration had all of these kind of thoughtful, creative ideas on ways to switch up the market, longer term plan designs, like 2-year plans that you sign up for, expansion of catastrophics. The big one that got a lot of press was the no network plan. People are very upset about this. And that final rule is pending, but has not come out yet. And so if you're, I mean, it's just been I know that no one is ever inclined to feel sorry for insurance plans, but man, like what a rough time to be an insurance plan in the ACA market. Like, okay, we don't know what the final rule is and exactly what the rules and regs are going to be for 2027. States are starting to collect that information. You had a fire drill last year where you submitted 2 sets of rates. You did the lower rates based on, maybe the enhanced subsidies will get extended, maybe they won't. And it went right to the end of the year where it was a sort of will they, won't they? And man, I don't know. It seems like a tough time to be an insurance plan in the ACA marketplace, which might be why Baylor Scott and White was like, oh, no, thank you.
Yeah. Do you remember Aetna, this is now months ago, decided to exit the ACA marketplaces. And there was a similar conversation, it felt like, that we had at that point in time of like, there's so much uncertainty that, maybe you're leaving some opportunity on the table as the market calms down in the coming years. But in this period of uncertainty, like why participate if you're a plan? I don't know.
Well, in the community this morning, there was a discussion, shout out to Lisa Berry, who posted about it, but Nevada is launching a state public option, basically. And normally when you hear public option, you think, okay, this is a plan that's run by the state competing with the insurance companies and acting as, a sort of self-regulating mechanism. Like one of the things that market-oriented public option proponents really like is they say, okay, there's this really great way where we can not do a ton of regulation. All right, we've got Shiv. I'm going to bring him forward, and then we'll go back to talking about public options in a little bit. Shiv, welcome to the show.
Hey, thank you so much. Sorry I'm late. I had some technical issues.
No worries at all. How are you doing today?
I'm doing great. Yeah, happy Monday to you guys.
Yeah,
happy Monday to you. Actually, I'm going to kick it over to Kevin because he was actually at JPM and has some thoughts on.
I love listening to your JPM presentation, as always, hearing you talk, Shiv. One of the framework that I left that presentation with and then saw again in your guys' news about the partnerships with JAMA, New England Journal of Medicine, was this idea of the pre-visit conversation, during visit conversation, post-visit conversation. It seems like the partnerships y'all announced are focused on the during visit conversation, clinical decision support as part of that. But I'd be curious if you could give us the lay of the land of how you think about the product offering today, expand on that pre, during, post, and how this content partnership fits into that.
Yeah, absolutely. Appreciate that. So high level, the mantra inside of the company, inside of Abridge, is that we want to aspirationally, we want to save time, we want to save money, and we want to save lives. And as a cardiologist, saving lives, we take that very seriously. It's aspirational to be able to demonstrate that. It takes time, but you got to start somewhere. You got to start with product. And when we think about product and the product user experience chassis, if you will, we think about what happens before I walk in the room to see my patient, what happens during that moment when I'm with that patient, and what happens after. All the work that happens afterwards in terms of looking things up or creating artifacts that I'm entering into any number of different systems of record, for example. But before the conversation, I might be prepping for that patient I'm about to see. I used to have a Monday morning clinic, a cardiology clinic, and every Sunday night I'd be in front of Sunday Night Football, just prepping my charts. I'd be looking up all the complicated patients. It would bring my blood pressure down. I'd feel a lot more at ease the next day that I could actually do a good job. Not only could I be timely, but I could actually be a prepared mind walking in the room, feel like, a little bit more of a superhero. But with this technology, we can, put that on steroids. Now, before I walk in the room, I can really know who this person is. I can even be cued on what questions I need to ask or what articles I should read. And those articles could be up to date. We've announced that partnership in the past. It could be from New England Journal of Medicine or from JAMA, but I can kind of walk in that room with a lot of the data, a lot of the evidence sort of contextualized to who this person is. And then I walk in the room and our ethos continues to be no distractions, eye contact, being present, no beeping sounds, no flashing lights. But when I look down or look to the computer screen, I should be able to get that cue on maybe, you should be asking these questions or considering this differential. And then afterwards, obviously, I can continue to query against all the context now, not just from the record, but also from the conversation that I had. Hopefully that kind of makes more sense.
I'd be curious if you wouldn't mind walking through a specific use case of this. Like in my head, I've got it as kind of Google search. I type in a question and it references the literature, but how does it fit into your product? And are you typing in questions? Is it ambient as well? How does it fit in?
Yeah, so maybe a couple ways I can describe how it fits in. One is through the technology actually very politely, very hopefully tastefully giving you cues. So saw a patient recently, and Chase, one of our clinician scientists, will bring up this example as well. The patient happened to have a certain type of medical history and also had a certain BMI. And I was seeing this patient for chest pain. And the usual course of action after chest pain in a patient who's got a lot of risk factors is to do some sort of risk factor stratification or like a stress test of some sort to sort of figure out what's going on. And I ordered a certain type of stress test, a nuclear stress test, but then afterwards, the technology cued me very quickly. It didn't call me an idiot, but it said, hey, do you want to reconsider the nuclear modality and think about doing a PET, like a MIBI? And a MIBI would be potentially a better choice, and you want to read more on why. And if I hit that button, I could very quickly look at the evidence, where that's coming from, whether it was an up-to-date article or a New England Journal of Medicine article. In that case, like I can actually go down all the way to the data and build a lot of conviction in changing my plan. If I want to change my plan, I can simply free text that. I can say, okay, adjust my plan to reflect this, and also adjust my orders to reflect this evidence or this data that I just learned about. So everything's like very deeply integrated with our enterprise positioning. I'd say like that's the most important aspect of all the product features that we build is trying to build as much trust as possible and feed as much context as possible.
One of the things that I find fascinating about this space is like it feels like up until maybe like 5 years ago or 4 years ago, clinical decision support was like highly algorithmic. It was like, okay, there's a drug-drug interaction and we can like surface that. And what that led to, I think, was some alert fatigue for doctors. They were getting kind of bombarded with like, you got these alerts. How are you thinking about, you've announced these partners with the New England Journal of Medicine and with JAMA. How are you thinking about the sort of the right context and sort of fitting those in so that it's not detracting from the sort of patient interaction?
Yeah, it's a great question. I remember those clinical decision support as a term too. It doesn't feel as cool anymore. It feels like clinical intelligence is the new way to describe the space. I used to be a corporate VC of sorts at a large health system at UPMC years ago, and we invested in multiple CDS companies. And at the time, you're right, it was basically best practice alerts. It was alert fatigue. It was pop-ups. And like the best you could do is surface a pop-up at the right time, at the right moment in a workflow, and try to introduce friction that a clinician might hopefully perceive as good. But this is a new moment where, especially when you think about products from like an AI first, from an agent first sort of standpoint, there's so much work that you can do in the background. And there's context that you can kind of engineer. The new term is obviously not just context engineering, but harness engineering, and how can you kind of safely lead the clinician to the right data to help augment their decision making, improve it. So to do this in a way that really works for us, evals have looked multifold. Like one is just quality. We score all of our outputs against a physician-built rubric system. Another is just testing for adversarial use, because I think you're speaking to, or we're speaking to, the user experience where it can feel pretty open-ended, and so jailbreaking can be a risk, and that you need to build the right guardrails into that harness to protect against that. And then another is just like straight safety from the standpoint of surfacing the wrong research papers, or the wrong drugs, or missing key parts of the context that you're feeding in the background. But we've now used, well over 1,000 really, really deep test cases to build rubrics developed by clinicians that kind of got us to this point of conviction that this is ready to go GA. And that's what we just announced. But it's a treadmill. Like, we'll always be running on it, just the way we run on all things related to like mid-revenue cycle and clinical documentation for that.
As an aside, as a MBA intern at Medtronic in 2010, I remember putting together a slide deck on clinical decision support and alert fatigue and how hot of a market it was
Yeah.
at the time. But just on this intellectual level, the idea of Medtronic getting involved in clinical decision support, I think, played into some of that alert fatigue. And when you think about the underlying incentives there, I'll leave that
Yeah.
aside for now. I'd be
Yeah,
curious, Shiv, to go back to JP Morgan presentation. You talked about, I think Abridge is live in something like 200 plus health systems today. A lot of providers are using it. It's used in a lot of patient conversations. I'd be curious to hear you reflect on state of play from a go-to-market perspective as an AI solution. Obviously, we have seen an explosion of health system interests in these sorts of tools over the past several years. It strikes me that if I'm a health system leader, I've probably thought about this question, have put in place the rails of what my AI deployment strategy is within the system at this point.
Yeah.
How do you think about conversations with existing systems, with potential customers about feature set, how you're building that out, how something like this fits in?
Yeah, it's go-to-market is everything, especially in healthcare. And like, people think that healthcare is one homogeneous market, and obviously it's not. And we think it's really difficult to swim upstream, but it's way more possible, feasible to go sort of go downstream from like those big systems, from the IDNs and the IDFSs and the payer providers and the AMCs. So we YOLO'd it, in 2022, 2023, and went to the big systems. And now over time, we'll start to expand and extend. But within those big systems, the barrier for good enough against even the first use case, like, is still high. Like, by that I mean like the threshold for good enough, because they need a solution to work in an enterprise grade way per the CIO that can help all their clinicians and all their specialties and all their spoken languages and all their different care settings. But then, what we quickly discovered is that there's so much more that you can extend into, whether it's moving upstream into what happens before that encounter, or downstream into what happens after. And like, as an example, like we might sit down with the CIO who's thinking about an ambient solution, but they're also separately, maybe a couple of years ago, they were thinking about a CDI solution. And then you sit down with them and you help them understand, actually behind the scenes, we can shift left on a lot of that CDI work and get it done even before the node is generated. And now you don't need to worry as much about CDI solutions for XYZ sort of, value. And it's an epiphany for them. And so it's the same story for prior authorization. There are a lot of health systems who were experimenting, especially a couple of years ago, with prior auth solutions that might live like downstream, and they're aggregating data across a lot of different systems and trying to help make the process for my back-end administrators a little bit more simple, helping them kind of get into those payer portals and upload all the PDFs or fax data, in a more efficient way. And then we would try to help them understand, well, actually, what happens if you just sort of shift left again and have these agents and sub-agents understand not just the context of who this patient is retrospectively, but hear the conversation, cue the clinician on gaps they should close, and then create all the right documentation and send it automatically to those portals. And even in the case of a couple different payers, actually round trip the authorization in real time. And it helps them sort of understand that actually, like, you can kind of collapse a lot of care delivery workflows if you start to just challenge your priors on what it could look like if you redesigned the entire system from scratch. And I think that's really the opportunity with AI, is to just like think about, collapsing and compressing workflows as much as possible.
I know we're getting close to time here, so last question for you is, one of the things we think about a lot here is like, okay, where are we going to start to see the impact of AI in healthcare? I think, there's some people who say we're starting to see it in coding, maybe in sort of ambient scribing and productivity. There are other people who are skeptical, and they say this is a Solo's paradox thing where you can see it everywhere except for, the consolidated financial statements. From your perspective, where do you think we start to see the impacts of AI in healthcare? Like, what are the things that you're most excited about, and where should we be looking for those green shoots?
Yeah, I've been thinking about this quote a lot. Like, there's a Bezos quote from years ago that when the anecdotes and the data disagree, believe the anecdotes. And that was very much like the story for us in like early days of scaling. We're now live in well over 270 large health systems on a run rate to be a part of well over 100 million encounters in the next 12 months, and hopefully a lot more than that this year. And early days, though, before we got to that scale, we'd have doctors tell us that for the first time they're experiencing Los Angeles rush hour traffic. And that felt like real, that felt like data. That felt like, a big win. But then we would go to that same system and that same user's sort of like data from existing telemetry systems, and there was no indication that they had saved any time. And we're like, what is going on? And so over time, and it's still like a moving target, we've realized that a lot of different systems are instrumented in different ways, and it can be pretty difficult. And so you try to find all the proxies you can for the value that you're trying to create. Save time, save money, save lives. I think that money piece is so important to us because like it's one thing to deploy an AI system and deploy it into the existing system without thinking about compressing and collapsing workflows and creating those efficiencies, impacting not just the bottom line, but also figuring out how you can find positive sum sort of models between all the stakeholders in healthcare, and thinking about payers and providers specifically. But that has to be the goal in our estimation, because otherwise we're just going to be deploying obviously like agents on top of existing workflows, and that Baumol's cost disease curve is going to look even steeper than it already does. So for us, it's a finite number of use cases that we're putting a lot of energy into that can demonstrate that win-win, where we're threading the needle through the most important people, patients and their care teams, those end users, but also those existing stakeholders. Prior auth is a really good example of that, but certainly a lot of the work that we're doing, like the announcement that we had with Availity, for example, at JP Morgan 2 is all about that.
Shiv, this has been hugely helpful. Thanks so much. If folks want to learn more about Abridge, though I think everyone listening has probably already heard of Abridge, where is the best place on the internet for them to do that?
Yeah, we'll do a better job of putting a lot more information on the website, but that's a good spot. LinkedIn is, I feel like, where you have to live as an enterprise healthcare company. And so probably our LinkedIn account is dropping as much information as anything else.
Great. Thanks so much for your time today.
Awesome.
Shiv, thanks for joining us.
Yep. Yeah, I really appreciate it. Thank you.
It continues to be, as we gear up for earnings season, I continue to be fascinated on where we're going to start to hear and see these efficiency improvements or productivity improvements for AI.
Yeah, I Shiv's point about when the data and the anecdotes disagree, believe the anecdotes, I think is an interesting one, and good one. And he made the same point, the story about the provider seeing rush hour traffic in LA. He made that point at JP Morgan. I think it's a really salient example of like, for the first time, these providers are going home at a reasonable hour, so they see rush hour traffic, right? Like, yeah, it's a good point he makes there, and it's a compelling story. To your point on earnings calls, the anecdotes fall flat compared to that one, right? And so, yes, like it'll be interesting to see where those anecdotes are that are actually finding meaningful progress.
I will also say, I spent some time with BLS wage data for doctors. And one of the things, depending on what deflator you use, it's like maybe has not kept up with inflation and PCPs are getting paid a little bit less than they were 10 or 15 or 20 years ago, or has kept pace with, CPI inflation. So a doctor's getting paid roughly the same. And when you talk to doctors, one of the things you hear is like they feel busier than ever. And so something that allowed them to sort of tread water and stay in the same place would be actually an amazing technology, right? If you're not getting paid more in real dollars, but you also get to go home and see your kids at the end of the night, like that seems like maybe a reasonable trade-off.
Totally agree.
Next up, we're talking about access. And so I'm curious if you have any, we have Patrick from Withings, a French company, though he's working on the American business. I'm curious if you have any thoughts on, any further thoughts on access. Like what is, as you are thinking about the program, what continue to be the open questions in your mind?
Yeah, so going back, because it's been an hour and a half now, since we talked about it last. So program announced participants on Monday, right? Withings is one of them. It was fascinating to me to see Withings and Whoop participate as kind of non-traditional healthcare participants, right? Organizations that are certainly in the ecosystem. I have been a Withings customer for years now with their scales, blood pressure cuffs, et cetera. Like it is one of those products that I think just works and works really well. So excited to have Patrick on here in a minute to talk about how they're seeing the world. But I think it is interesting to see the participation there from those two companies in particular and think about what that implies for the access model and how, if the theory of the case coming out of CMMI is we need to use AI to bend the cost curve. We want to target kind of the lower risk Medicare population and potentially use that to work our way up and expand over time. I actually think that's a really logical theory of the case that this would be a good place to start, right? And so I'm curious. Like to me, that's kind of the thought exercise that I will probably be thinking about as we watch access roll out over the coming months. Is like, can you rethink it from that direction? Because obviously we saw in the announcement on Monday, digital health doesn't seem to think that you can rethink it when you are coming from kind of the traditional lens, right?
Yeah. Tech-enabled services is one of those things that, comes in and out of popularity. And it feels to me like CMS is saying, we want it to be, we want to really underscore and underline the tech side of it, which is what makes the Withings and Ura participation so fascinating to me. I think
Ura is not in it. I think you meant Whoop.
I did mean Whoop.
Ura did not participate, which is also interesting, but probably a different conversation.
Yeah, and so I think that when I think about behavior change, I think behavior change is really hard. And I think that one of the things that you sort of need for behavior change to work is some sort of real-time feedback. And so the more I think about it, the more it makes sense to me that a connected device company would be able to better provide that real-time feedback than something that is purely digital health focused.
Totally agree.
All right, I am going to bring Patrick on up. Hey, Patrick, how are you?
Martin, Kevin, great to see you guys.
Good to see you, Patrick. Welcome to the show.
Thank you.
As you probably heard us just teeing up, we're excited to talk with you about what y'all are up to at Withings, the access model in particular, how you're thinking about the opportunity there. So maybe let's start with that. I'd be curious, as one of the 150-ish participants in the model, how are you thinking about the opportunity? What gets you excited about the model? What led you guys to apply?
We're very excited, and thank you, Martin and Kevin, for having us on and talking about access. Look, I think access is like a big moment for digital health, and you guys spoke about it very well. Like, why hasn't digital health come more to the table? And maybe like the role of the device is like really important here. But the more that we got into the weeds of access, the more we spoke with Jacob and company at CMMI, the more we were like, actually, this is a great model for a device company, and all of our expertise in delivering care and enabling care in the Medicare population. And what we think about it is, look, the hardest part in all of this is getting a patient to use a device. I think a lot about like the payment is fully contingent on a patient using a device for the baselining, for the quarterly payment, for the end of year payment. The device is core to all of this. and we also know that patients love using our devices, and that blend of like consumer plus we have huge amount of healthcare partnerships with ACOs, health systems, getting data back to PCPs. I could talk endlessly about it, but we felt more and more that the people who were going to succeed in this model are those who have that consumer backbone, but also have the right pipes into the healthcare system to have that coordinated collaborative care approach for the patient.
The main thing we've heard from folks who are not participating is some complaints about the rates. Obviously, we're not looking for you to get into your secret sauce here
Yeah.
on how you did the math, but curious for your high-level reflections on how you interpreted the rates, what you're sort of seeing as the opportunity here, and how you're thinking about, leveraging AI to help make this stuff work.
Yeah, so the rates as they are today are sustainable for Withings, but Withings were kind of, and other device companies were kind of unique because we own the main cost structure in this care, which is the hardware required to be able to manage the patient remotely. The way I think about it, and you guys probably think about it the same way, but this is a pilot, and we're coming in the first year, the first cohort. I think a safe bet is that this is going to evolve as time goes along as well. So like as the rates are today, we're very happy with them. We're looking at a sustainable business in access alone, but we're also really thinking about, hey, this is the start of a pilot with CMMI. This is going to evolve quite rapidly. We were talking about, we're all rooting for this as taxpayers, right? For this to succeed. You guys were opening up with that today. I think about MSSP, like in 2014, PCPs were saying, we can't do this. Like, this is too low of a rate. It's not going to work out. And you fast forward a little bit and you had these insurgent models, right? You had these enablers pop up because they had the core technology of like pop health analytics, really robust to enable that payment, enable success in the MSSP program. I think access is kind of the same way, where the incumbents, this is difficult in the status quo, but we're going to have this insurgency of companies who have the right technology in place, who can build for it. And I think this will be a very successful program with the right people at the table.
Patrick, I think most of us think of Withings as connected device company, manufacture scales and blood pressure cuffs. People use them in their homes. To be part of this program, I'd be curious, are you expanding scope of Withings? Like, there's been conversations about becoming Medicare provider, Part B provider to participate in the program. What have you had to build on top of kind of the core connected device offering for access in particular, and how you're thinking about that moving forward?
Yeah, so we are a Medicare Part B provider today. I think of it as, one, it's a natural evolution of what we do every day. So Withings, we have 15 million users around the world. Kevin, I know you're one of them as well. We have a million medical patients being monitored today, anywhere from 1 million to 1.5 million on a given day with our healthcare partners. Like, we know what works in managing hypertension. We know what works in managing obesity, et cetera. So we have formed, our Part B medical group. And what we're building out, and we'll announce our clinical leadership as well, but what we're building out is a care model that's focused on being this new layer of care. And this is where I spent a lot of my time, Kevin and Martin, thinking about with our ACO partners is, where does our care begin and where do we bring it back to you guys? And that's why I'm kind of urging the full access cohort is, hey, don't go at it alone, guys. Because if participants start going at it alone, we're going to create friction with the ACOs, with the health systems, and I think that's how the pilot fails. I'm like really urging participants to really think about how you integrate back, how you coordinate back with the ACOs, with the health systems.
I think that's one of the things that I'm most fascinated by is what, how ACOs are thinking about this, how those conversations with ACOs are going. I'd be curious if you can kind of give us any sort of initial reflections or reactions from the sort of Withings plus an ACO on what this could look like.
Yeah. This is where I'm spending like all my time. It's really exciting. I love it. I think it's like, this is the evolution. RPM was like a false start in hindsight, all things considered, for this purpose. So today we have a number of ACO partners doing remote management of heart failure, hypertension, obesity management. Most of the conversation today is how do we work together to avoid possible fragmentation of care? That's the number one focus today. And we are operating from a place of, okay, how do we ensure that a patient is, one, has the choice? Because this is really the core pillar. And actually, guys, we need to speak about this. But the thing I'm most excited about with Access isn't the outcomes-based payment. I think that's kind of table stakes for this movement. It's patient choice. The idea that a patient's benefits isn't limited by who the payer has contracted with and is a complete open kind of app store approach to the benefit, I think is transformational, and I think other payers will probably follow suit. But that patient choice also means that there's a risk of fragmentation of care for a PCP. So you might have a patient panel if you're 1,000, 1,500 patients, and then they're in a couple hundred different programs, they themselves, right? And that's very complicated. So how do we preserve patient choice, but also ensure that we're coordinating back in a way that doesn't create friction with PCPs and hinder the growth of the Access pilot?
Picking up on that choice, one of the prerequisites in that is awareness, and that's been a big part of the topic of conversation with Access is how is the program actually driving awareness of these decisions with patients? How, with Withings and the installed base you already have, I would imagine that creates a channel to go create awareness within that. But I'd be interested in how are you thinking about driving awareness? Do you expect, are the 65 plus population going to be getting flyers in the mail starting on July 5th being like, hey, come use us in Access? Or what does this feel like as the program goes live from an awareness perspective?
I'll tell you, we're still thinking about the playbook. There's a lot of gray area in Medicare marketing because a lot of it's been written for Medicare Advantage, and we're trying to get clarity and about what meets the intent here. But I'll tell you what we want to avoid is, the 9 p.m. you're watching, CNN, MSNBC, Fox News, and you get a commercial for Withings saying scan QR codes. We're trying to avoid that because I think that's where this pilot access model falls apart, is that type of behavior. From an awareness perspective, we're thinking about how we can best serve our consumer base. We ran a couple surveys with our 65 plus population, and we have I think over 1 million to 2 million 65 plus in their consumer base, and the number one thing they're looking for is actually hypertension management.
Really?
And that's across scales, blood pressure cuffs, wearables. They're looking for help with their hypertension, and that's great, and we can offer that. But we also think about it like, hey, the number one most impactful intervention for a patient, sure, coming into Access is great. We need to get you to a PCP. You know what I mean? We need to get you in front of a PCP, and we can help you with that, and then come into Access. So the more we think about this, the more we think that the point of Access is for tech companies like Withings to come to the table and have, place our chips on the table, like, hey, we're at risk on the outcome. But this only works if we have other stakeholders at the table saying, hey, I'm accountable to total cost of care, and I'm thinking about the full, care plan of this patient. We think we have to come at it as a team with the rest of the market.
One of the things that I find fascinating about the access model is CMS has lined up a bunch of payers in the commercial space and Medicaid space and MA space to commit to, in principle, to a similar payment model. I realize that the access model hasn't rolled out in the original cohort yet. I'd be curious, though. You mentioned 1 or 2 million on the 65 plus, but there's also probably a lot of commercial folks. And when I look around my gym, I see folks with Withings watches. How are you thinking about the commercial market for this?
If I'm a payer, why would I not do access? Obviously, it has to be successful, right? But it's inherently deflationary, right? And you're solving for a huge burden, which is contracting for benefits. If I'm a payer, this is very attractive. I think a lot of this comes back to, is it going to work from a, how do access participants work with the provider network? And I think it's gonna be a lot of the relationship. Yeah, I mean, we obviously would invite this to grow to other payers, and it'll be the same approach, right? Where we have an embedded consumer base, we have partnerships with health systems, ACOs, who are also managing commercial ACOs, managing employer-sponsored programs, and being able to do the access model there. But we're really thinking about the first participation period, the first period, performance period, and coming back to, we want to ensure that the full model is successful. I think another thing that's like piggybacking access really closely, and maybe this is the true purpose of access in the market, is going to be CMS balance and the expansion of the GLP-1s starting in July. I know, Kevin, we spoke about this a few weeks ago too. And as we can anticipate wide distribution of GLP-1s to a senior population that has frailty and risk of falls and other adverse events, things like access might be part of the infrastructure for that population. I think of remote monitoring and technology, device-centric care as being great paired with medication management, paired for medication safety. So I think there's a lot of value in the commercial population, but I'm really, really focused right now on that first performance year and what is access as a new layer of care, because it really is something new, and defining that with the rest of the market.
I'm curious to go back to the survey you mentioned, Patrick, and the data you talked about on patients. And I'd be so hearing that there is such an interest in hypertension management, I immediately start to wonder, what is their relationship with a PCP like today? Like, yeah. I hear, one of the veins of pushback I hear against access and thinking about using technology in this way is displacing the relationship between somebody and their PCP and concerns around that and what that all implies. But when I hear that from the survey results, I'm like, how close of relationships do these people have with PCPs today, and what does that really look like? I'd be curious, any reflections from the survey, things you heard from that, lessons learned about what the state of that actually looks like in the Medicare population using your guys' devices right now.
Yeah, we don't have that direct data, but that's where we need to be thinking about, right, Kevin? It's, and I think that's how we're trying to, at least Withings' access participation is being defined by how do we augment as a new layer of care for the PCP.
Yep.
And I think access is also kind of like a new tool in the toolbox for an ACO to be doing a better ACO lead program. Or if you're doing ambulatory specialty model, here's a layer of digital care you can add on top of it. So I really think of it as being more like a utility. Like, I think the core principle, or at least what gets me excited every morning, I'm up every morning just ready to go, because I think of it as like we're providing patients this new always on level of care. The assumption is that everyone with a chronic condition should get some level of support day to day. And much like we give people electricity, water, heat, let's give them a layer of care that's going to be with them. But we can't replace the PCP. I think it's really important that the broader access cohort be respectful of that relationship.
Patrick, this has been hugely helpful. We will definitely have you back once things get kicked off, so you can share how things are going. In the meantime, if I lead an ACO and I want to work with Withings, what's the best way for me to get in touch?
Yeah, always visit our website. We have a professionals page as well, but otherwise feel free to reach out to me directly, first name, last name, patrick.sheehan@withings.com. Very transparently, I think what ACOs are enjoying about talking and working with Withings is that there's no playbook that's been built, and we're trying to build it with them. It's been a very exciting few months, to say the least.
I can only imagine.
Sure.
Thanks so much for your time today, Patrick.
Yep.
Thanks, guys.
Good seeing you.
Take care.
Martin, I feel like, the feedback we hear from digital health circles coming out of Access these days is like, how does this all work? And I think we just heard the narrative of how it might work, right? Like, when I think about the insurgents versus the incumbents conversation, I think we found the insurgent.
Yeah. I also think, you have this funny, we when we're communicating about things like this, we tend to think of them in very two-dimensional ways. It's like, well, someone with a Withings device is probably not going to be the sickest, highest acuity or whatever. But you do have this interesting mix, which is like you have Withings customers who are worried about hypertension, who are have this tool. They've like gone out and done this tool. Like,
Yeah.
it would be great if they were not, clogging up their cardiologist's schedule, and instead we're working with Withings and their ACO. And I don't know. I think that some of the criticism I've heard is it feels like sour grapes, basically. After that conversation with Patrick, I'm even more amped for what they've got.
Yeah, I mean, I think it's great. I'm excited to see it roll out. Let's go.
One thing I wanted to ask you about before we go, there's been a couple funding rounds this week about risk adjustment and risk adjustment startups. Did not have that on my bingo card in the last year of V28. And so curious for your sort of parting reflections here.
Yeah, so we saw Keebler Health got $16 million. Flare Capital led the round. It's AI platform using clinical care. First use case is risk adjustment purpose. Broadly speaking, it's trying to support population health use cases. Listen, I think it's an evolution in the market, right? We've had a lot of conversations recently about risk adjustment in clinical care and the opportunity for AI there. And I think this is a reflection of that. And I think we're going to be talking a lot in the coming months, years, as we already have been now, coming out of Payer's earnings call recently, about what is actually underlying that and digging into that. I would hazard a guess that Keebler would make a good case on a show like this, that it is not actually upcoding or things you might not want to design for. It's actually capturing what's happening in the visit. And I think that is a fascinating question to think about. Joyful Health, the other funding round that we covered this week, they raised $22 million as a revenue cycle tool that helps providers capture revenues. So adjacent space in many ways. And I thought it was interesting because I think it was their funding announcement mentioned that providers are losing out on $125 billion a year of earned revenue. As I hear that, I mean, that 125 billion is what? Like, that's 0.5% of GDP or something like that itself. Like, it's a huge number, but it's actually like, okay, providers have not been capturing what they earned effectively pre-AI. And now AI is actually introducing that tooling in. And it feels like there's an answer to this question underlying it of like, what actually happens in the visit and what is earned versus what is additional capture, that we're all going to be wading into moving forward, whether or not we want to. And payers are going to need to catch up on the tail end of this, whether or not they want to, right? It's a brave new world we're entering.
Truly. I mean, this is, I guess, one place where we have seen productivity improvements as a result of AI on earnings calls is hospitals' volume flat to flattish, but revenue per patient or admission going up. Like, that's a productivity improvement, right? If you're getting more money for the same volume of patients. And that's something we're going to have to deal with because that's inflationary. That means we're spending more money on healthcare.
And the question is, like, what does a productivity improvement mean? Like, nothing might actually be changing in the real world. It's just there was inefficiency in how previous eras of billing systems captured what happened in the real world, right? Like, we see this a little bit with that sepsis case in Massachusetts that we were talking about a few weeks back, of sepsis diagnoses are going through the roof. Payers are upset about that. What's going on underlying that? And there's this question of like, is anything changing in the real world, or are we just capturing data differently to reflect that? And I don't know the answer to that. It's going to be interesting to watch that evolve. I know that.
Yeah. Well, I feel like that's a good place for us to end it. Kevin, thanks for your time today.
Fun as always. Talk to you soon.
Yes. Talk to you soon.
Yes. See you, Martin.